We're going to turn it over to Dr. Chakarun.
We have a great group of people here at Shin Imaging. All of our radiologists are board certified and have completed additional fellowship training in subspecializations such as neuroradiology, interventional radiology, mammography, body imaging, and musculoskeletal radiology. A little background about myself. I trained at USC LA County for radiology residency and completed an additional one-year fellowship in musculoskeletal imaging. And during that time, I was able to work with a lot of the USC athletes, including the USC football and basketball teams. For instance, Mark Sanchez, pictured here, was injured and had his imaging completed at USC. So I was involved in interpreting their imaging studies, performing imaging-guided procedures such as steroid injections and arthrograms. And then later I would have the chance to watch some of the athletes compete on television. So that was a great experience for me and definitely a lot of trauma. So what is a musculoskeletal radiologist? An MSK radiologist is subspecialized in imaging and imaging-guided procedures related to the musculoskeletal system. For instance, this is a paper that we published in AJR regarding orthopedic hardware. The images on the right demonstrate placement of an endoprosthesis for limb-sparing surgery in the distal femur and proximal tibia. And this was a project that we completed in collaboration with Cedars-Sinai. We worked side by side with orthopedic surgeons, obtained intraoperative imaging, and correlated the findings in the OR room with what we saw on the plain films and advanced imaging. MSK radiology also focuses on bone disorders and bone tumors. For instance, we published this paper in the Journal of Radiographics on giant cell tumor of bone. The image on the right shows giant cell tumor extending through the distal femur, labeled by the arrows here. And MSK radiologists perform bone biopsies and other imaging-guided procedures. So in this image, I used a drill to enter the cortex of the posterior right iliac bone. And then after drilling through the cortex, went down, advanced the needle, and took a biopsy of the sclerotic lesion. And this ended up being a prostate metastasis. And before I discuss trauma, I want to highlight a case from Shin Imaging that was recently accepted in the E-Anatomy Atlas of Human Anatomy. This atlas is used by radiologists across the country and throughout the world. I personally used it as a radiology resident, and it's also a resource for medical students and faculty for teaching. And here's that patient from Shin. The patient was a 19-year-old male, and as you can see, the imaging is very high quality. This slice is right through the level of the glenoid labrum, which is outlined perfectly here. And the bright signal is the contrast from the joint injection, outlining the glenohumeral ligaments. So just some beautiful image quality for the anatomy, and this was published a few months ago, January 27th, 2020. And I'm grateful to be working at an imaging center with such high quality images that are worthy of publication in an atlas. So what is the role of magnetic resonance imaging in musculoskeletal trauma? Well, Dr. Lai and Dr. Cressy mentioned some of the uses of MRI and the role. So I'll discuss them here. Osseous contusion or bone bruising, hemarthrosis or bleeding into the joint, occult fracture, which is a fracture that can be missed on plain films or other imaging modalities, but is detected on MRI, and muscle tear, tendon tear, ligamentous injury, avulsion injuries, and cartilage injury. Bone bruising or osseous contusion is injury to the trabecular portion of the bone. So the image on the right shows that bone has a cortical outer layer of hard bone, and inside is what's referred to as spongy bone or trabecular bone. And the image on the left is a scanning electron microscope image that shows this meshwork and trabecular pattern. So bone bruising or osseous contusion is microtrabecular fracture. And within these spaces and holes of the spongy bone or trabecular bone is blood vessels and bone marrow. So when there's microtrabecular fracture, there's injury to those vessels and the marrow. And this is what it looks like on MRI. This is a sagittal image through the lateral compartment. And as you can see, there's bright signal in the lateral femoral condyle and the posterolateral tibia from osseous contusions. And this specific pattern is referred to as kissing contusions. In other words, there was anterior tibial translation, which is usually from an ACL tear. And this part of the tibia impacted upon the lateral femoral condyle, leading to the bone bruising. Hemarthrosis is bleeding into the joint or hemorrhage into the joint. And this is a specific type of hemarthrosis called a lipohemarthrosis. And this occurs when there's a break in the cortex. This dark line here is the cortex or the outer portion of the bone. And when there's a break in the cortex or fracture that extends to the joint, the marrow leaks into the joint. And we have a trilaminar appearance referred to as the Neapolitan ice cream sign. And the Neapolitan sign, the star here is labeling the non-dependent portion of the fluid, which is the fat from the marrow. The middle layer is the serum, and then the more dependent layer is the blood product that's more dense because the patient is supine on the exam table. MRI is superior in detecting occult fractures and subtle fractures that are missed on plain films and other imaging modalities. This is a case of a 27-year-old patient, and the frontal view plain film on the left was interpreted as normal. However, when the patient went in for MRI, we can see that there was a curvilinear low signal fracture line in the medial tibial epiphysis and metaphysis with surrounding marrow edema. This is an occult fracture of the ankle, and the plain films were interpreted as normal, but as you can see, MRI clearly demonstrates the curvilinear low signal fracture line extending to the talar dome and also the posterior subtalar joint with surrounding marrow edema. So how does 3T stack up against 1.5T for bone stress, fractures, and marrow edema? Well, it turns out for this particular type of trauma, there's not a big difference. Osseous contusions and fractures are pretty well detected, whether it's 1.5 or 3T. The only finding from that particular article is that the demarcation of the marrow edema is better delineated on 3T imaging. So there may be some uses for that, but overall not a huge difference. However, when comparing 1.5 Tesla and 3 Tesla for small joints such as the wrist, 3T is superior. Specifically, if you're looking for injury in the wrist, such as injury of the triangular fibrocartilage complex, the sensitivity, specificity, and accuracy of 3T MRI is higher compared with that of 1.5 Tesla wrist MRI. And here's an example. The image on the right shows the triangular shape of the triangular fibrocartilage complex, and MRI demonstrates a full thickness tear or central perforation of the central disc, as well as an additional partial thickness undersurface tear. And Dr. Lai mentioned using MRI to detect injuries of the thumb. So this is a case from Shin, and the plain films were read as normal. However, on MRI, just like Dr. Lai's patient, there's a full thickness tear of the radial collateral ligament of the first MCP joint of the thumb. And you can see the dark fibers here where the ligament is intact distally, but proximally it's torn, and some marrow edema in the first metacarpal head. This is another example from Shin of an avulsion fracture. And we talked about the timing of injury. And in this case, I can tell that the injury was at some time in the past because there's no marrow edema. But it was helpful because they suspected ACL injury due to trauma. And as you can see, the fibers of the ACL are intact. However, they're attached to this 3 millimeter avulsion fracture fragment which came from the anterior tibia, the medial tibial spine. So I've discussed bone bruising, hemarthrosis, occult fracture, muscle tear, and some of these other injuries. Now I'm going to focus in on cartilage injury, especially because 3T reigns superior. And here's just an article, a retrospective study in which patients were imaged at both 3T and 1.5 Tesla for injuries of the knee. And the first case from that study, a 35-year-old male who reported locking and pain in the left knee. The image on the left is at 1.5 Tesla. And the radiologist read this as questionable signal change at the patellar cartilage. However, when the patient went in for 3T MRI, the corresponding abnormality was correctly identified as a greater than 50% thickness patellar cartilage lesion, and this was confirmed at arthroscopy. The second case is a 37-year-old male patient with swelling and contracture of the left knee. And in this case, no cartilage lesion was detected at 1.5. If you follow my pointer here, the gray signal of cartilage along the patella is intact. The cartilage along the trochlea was intact with no lesion. However, at 3 Tesla imaging, this was correctly graded and demonstrated a greater than 50% thickness cartilage lesion along the lateral patellar facet and verified by arthroscopy. This case is a 36-year-old male with suspected osteochondritis dissecans. At 1.5 Tesla, there was high signal along the subchondral bone that was thought to be delamination without a focal cartilage defect. And again, following this arrow, you can see that there's intermediate signal, this gray cartilage that looks like it's overlying the lesion. But when there's delamination, this can occur, but you want to look for the part of the delamination of cartilage that's extending to the articular surface. So the patient underwent imaging on 3T, which clearly demonstrates a full thickness cartilage defect with delamination, and this was confirmed at arthroscopy. And again, I just want to drive this home. 1.5T did not detect a cartilage lesion here. Maybe in retrospect, there's a small focus of signal change, but a cartilage defect was detected on 3T. And from our imaging center, this is a recent case where the patient had trauma. I think it was a twisting injury, and beautiful image quality. The cartilage is intact here following the lateral femoral condyle. And then right in the posterior weight-bearing portion of the lateral femoral condyle, an 11-millimeter full thickness cartilage defect with just a sliver of subcortical edema. And when you see a cartilage lesion that's this large, you want to look elsewhere in the joint to find that fragment of cartilage. And sure enough, it was found higher up in the suprapatellar region. This is the displaced cartilage fragment. And I called the orthopedic surgeon who referred this case to Shin, and he later took the patient for arthroscopy and confirmed these findings. So the most important takeaway message from this lecture today is really two things. Number one, 3T is superior to 1.5 Tesla in the detection of cartilage injury and cartilage lesions. And number two, for small joints such as the hand, wrist, fingers, and ankle, 3T is better than lower field magnetic resonance imaging. In summary, I've discussed the advantages of MRI over other imaging modalities, the types of MSK injuries detected with MRI, and the advantages of 3T over 1.5T for MSK trauma. Thank you for listening, and with that, I'll turn things back to Tom.
Let me actually ask you a question, Dr. Chakarun. You're not off the hot seat yet. I'm just kidding. With imaging, you know, we deal a lot of times with non-obvious injuries. Is there anything, you know, if you don't have a fracture or if you don't have obvious edema, when you're looking at an MRI or maybe another type of imaging, are there signs or clues that tell you that something's acute rather than chronic or long-standing? I mean, and I guess we can leave it open to maybe shoulders or knees or ankles or hips or even the spine?
Sure. Yeah, absolutely. Um, I'll give an example. So the case that Dr. Lai showed with the knee for that soccer player that had a chronic tear of the ACL, I could tell right away, I see him nodding his head, I could tell right away it was a chronic tear because there wasn't marrow edema, there wasn't much anterior tibial translation on the image, and those are secondary signs of ACL injury that we see. So probably the ACL was torn because it wasn't visualized, but it probably scarred down over time.
And is there something that we can say is acute at times on imaging where you, as a radiologist, you're looking at it and you say, wow, okay, that's clearly acute?
Right, yeah, absolutely. We look for marrow edema. We see fluid signal, we see subcutaneous bruising, joint effusion. There's a lot of things that we use to piece it together. And usually, at least for a musculoskeletal injury, we can usually say whether this is acute and related to the trauma or not. We do get some referrals where the patient had an MVA that's 2 years ago or a year ago. And in those situations, it's kind of difficult because we don't have the secondary signs or the bone bruising, the edema, all of that is resolved. But in general, as long as you get the imaging done quickly, like Dr. Cressy mentioned, then yes, we can usually distinguish that.
Thanks, doctor.